Hello, and welcome to another PowerPoint presentation by myself, Dr. Barbara Dantzler. This presentation is emotional and mental assessment of the older adult. And I'm hoping to, when this PowerPoint is finished, that you will meet these learning objectives, that you will be able to discuss techniques used to assess the mental health issues common to older adults, discuss the assessment tools available to assess mental and emotional health, and recognize the mental and emotional health issues of the older adult. So let's get started. Before you are able to conduct a complete and accurate emotional and mental health assessment, you have to determine what's going on. The first thing you're going to look at is any cultural factors to consider, because cultural factors will dictate the person's behavior. So you need to be aware of those. Second, we have to know their cognitive function level. Are they cognitively impaired? Do they have dementia? And otherwise, we have to know that so that we can select the correct tool to do the assessment. And we'll learn more about the tools shortly here. And the other last thing you need to consider is there any organic or physical condition that's causing the unusual behavior, such as something that will be classified as delirium. And we'll talk a little bit about that as well. So let's look at the cultural factors in mental health. The mental health of minority older adults tends to be better or at least as good as the more general white older adult population. Some cultures believe that certain illnesses are attributed to religion or personal weakness, punishment for a sin that they've done, or even possession of an evil spirit. So with so much diversity, it is better to ask the patient what they're feeling and what do they think is causing their distress. The symptoms of interpreted behavior are called the idioms of distress, and many ethnic groups are likely to express mental distress through physical symptoms. This is experienced as body sensations that cannot be explained biomedically. For example, a person who is depressed may complain of dizziness, pain, fatigue, rather than the sadness and loss of interest in life. If any of you have ever been like really down about something for an extended period of time, you'll notice that you may have had a headache because of the depression or a loss of appetite. I myself have experienced like a chest pain because of increased anxiety over a situation for a long period of time. If a person feels that they are bewitched, are being possessed by something, or there's a spell been cast on them, they may exhibit signs of anxiety because they're worried and concerned and trying to figure out how to get the spell off of them. Family also influences the person's reaction to different situations, depending on who is considered part of the family. And you have to recognize that some cultures count extended family as immediate family, and others even extend their family out to the community. So the community is the family. Many groups also believe that mental health issues are to be handled by the family, so they don't share those feelings with outside people. And shame and stigma run high in some of the groups as well, meaning that to have any kind of mental health condition, it's very shameful and it should be kept secret. And they won't let you know what's going on, or they won't express that they're having these feelings towards you. So we have to consider that as well. Some groups, especially Asian Americans and Hispanic Americans, have a hierarchical order. So there is the person that's in charge or at the top who makes all the healthcare decisions for that particular group or family. So we have to consider that as well. And then another factor about different cultures is fear and distrust, especially if the healthcare provider comes from a different background than the patient themselves. They just don't trust you, and they're not going to really open up their feelings. So you have to consider all of these. Another thing is that minority groups in the United States are less likely to seek mental health services, or more likely to delay seeking health care services or have little access or knowledge to mental health care or lack of insurance coverage and financial socioeconomic status has a lot to do with people seeking help for something such as a mental health disorder. So we have to consider that as well. So let's talk about delirium. I hope you like my little picture that I found here. This guy seems to be experiencing something that is quite bad, delirium here. The word delirium is from the Latin word delira, which means not on track, which is kind of what's going on. Delirium is defined, if you want a more professional definition, as an acute reversible neuropsychiatric syndrome manifesting as a confusional state characterized by an impairment of cognitive function, meaning impairment in thought, perception, or recall, or a acute, which can occur suddenly in hours or days onset with a tendency disturbing of consciousness or attention. Um, those with delirium exhibit a reduced ability to maintain attention to external stimuli. They have disorganized thinking patterns. They may ramble. Their speech may be incoherent. They may also experience reduced levels of consciousness and sensory perception. There'll be disturbance in their sleep-wake pattern. Either they'll sleep a lot or they can't sleep at all. Reduced psychomotor activity, memory impairment, and disorientation to time, place, and person. Now, those definitions or those possible symptoms are from the DSM 4, just in case. So, there are different causes for delirium, especially when we are looking at older adults. Changing their environment is one biggie. When an older adult is ill and has been taken to the hospital and perhaps is in ICU, they wake up, they have no idea where they are, and they may exhibit delirium like behaviors. Common for older adults is after a surgical procedure. They are experiencing delirium. They don't know where they are. They begin to panic. Dehydration can cause experience them to experience delirium. Drug toxicity or withdrawal from a drug or certain medications like a hypnotic. An older adult can have a urinary tract infection and present to you as if they were an Alzheimer patient until you find out the history and that the person has not had those symptoms before. Give an example is in the emergency room, a family brought in their elderly mother who was disoriented to time and place and person. She was very agitated. Her speech and pattern didn't make any sense whatsoever. She was referring to things that were not there, and you would have assumed that she was suffering from some sort of dementia. But after taking a history from the family, it was determined that this behavior had come on suddenly and that before she was very coherent and cognitively intact. Further investigation and lab work shown that she had a urinary tract infection. Once put on antibiotics and IV fluids and the antibiotics were allowed to work, the lady returned to her normal pre-delirium state and she was perfectly fine. TIAs or strokes can be presented as a type of delirium behavior. I had a patient who lived at home with his family and I would make home visits and he was always very cognitively intact, very appropriate. But on one visit, I noticed that he was not speaking the way he normally did. He was rambling and some of what he was saying was not making any sense. He was up and walking, and I didn't see any other physical signs of anything else going on except for the fact that he was just not himself. The family reported that lately he had been kind of forgetful and confused. So knowing what I know, I had him go to his physician, and it turned out that he was having TIAs, which was causing these little episodes of delirium. Now they weren't consistent. It didn't. He didn't stay in a delirious state. He would come and go, and he was coming and going as he was having the TIAs, or transient ischemic attacks. For those who didn't know what that was, okay? Older adults can go into delirium from fractures, any type of traumatic experience like burns or falls, pulmonary embolism, and other things. So it's very important to recognize the symptoms of delirium very, very early so that you can treat them, because it is a common thing in older adults, but it can be preventable and it is often reversible. However, if you don't treat it and address what's causing it, it could lead to permanent new dementia, and other falls and loss of their ability to take care of themselves, urinary incontinence, emotional and physical decline, social decline, and eventually death. So it is important that we recognize these sudden changes in their behavior and their mood. Delirium is also associated with higher healthcare costs, longer hospital stays, and delayed rehabilitation for these patients. If you're assessing a patient with possible delirium, one of the first things is look for the signs and symptoms that I just described to you. But again, speak to the family, because if you're seeing them for the first time, you have no basis of how their behavior was in the past. Is this something that was ongoing, or is this a sudden thing that has occurred within a few days or a few hours? Once that is, you've gotten a good history, or if you don't have family, go back into medical history charts if you have that ability, and note whether it was addressed earlier, or is it something that is fluctuating, or no history of it in the past. The CAM, confusion assessment method, is one of the methods for determining and assessing delirium, and it allows you to arrive at a possibility that the patient has experienced delirium. You notice the first one is, does their abnormal behavior have an acute onset, or is it fluctuating? Is the person characterized by inattention or difficulty concentrating, or having trouble keeping track or up with what you're saying to them? Is the person showing disorganized thinking, like rambling, or their speech is very difficult to understand? Are they jumping from subject to subject? Does the person demonstrate any alteration in their level of consciousness? Are they lethargic, or in a stupor? Are they just really, hypervigilant, or what? Once you have answered these questions, then you need to look at if the patient is demonstrating both number 1 and number 2, as well as 3 or 4. You can pretty much say that they are having a delirium attack. The only people that can do these and diagnose the patient are those who it is within their scope of practice to give a diagnosis, and they're licensed to do such. However, the CAM still can be used to report to the primary care provider when you suspect delirium. So you can still do this. You cannot give the diagnosis, but you may still do the delirium assessment, the CAM, and then present it to the healthcare provider and let them make the diagnosis. If you want to see a little bit more details about CAM, go to the Try This series in the Hartford Institute of Geriatric Nursing. Next is depression. And for older adults, it is very high, and it often goes undiagnosed. It is one of the most common mood disorders in later life. It's difficult to diagnose an older adult because they don't display the same symptoms as others will. Their symptoms do not match the DSM-4 classification of symptoms for a depressed mood. It is also good to know that Alzheimer patients still can have depression, but it's often overlooked, undiagnosed because of the other signs and symptoms that they are having. The group of older adults that are depressed have a poor quality of life. they have faster cognitive decline. So if they're already depressed, then their cognitive ability will decrease. And they have a higher mortality rate than those patients who don't have depression. And so depression affects the person's moods, the person's behavior, their functions, their thoughts, and even their physical health. So it's something that um, that we need to be cognizant of. So how do you recognize it in older adults since they don't present it the way that you would consider if looking at the DSM-4 classifications? In this picture, you see two people who on the outside who look obviously depressed, and the person in the middle, do they look depressed? Well, look at him. He's looks like he has his mouth open. He looks like he's in a new environment. Perhaps he just woke up, and he in the middle I would consider delirium. And I just threw that in there for you to get that picture, maybe, at first glance when you look at someone. So again, it's hard to identify depression in older adults, and it could be considered. And people think of it as, oh, that's just a normal part of aging. They're slowing down. Oh, that's a side effect of their medicine, so forth. Or it's just because they're older and it's decreased function. Um, but you also can have an older adult who presents with what we call an agitated depression, when they feel like things are just like churning on the inside of them, and they just started feeling sensations of heaviness in their chest or heaviness on their body, or they may become lethargic or even have physical pain. So if you have a patient that reports to you all the time with physical pain, but there's no uh, physical reason for that pain, you may want to suspect depression. Sometimes they can't digest their food, but they also may, when you interview them, deny that they're even having these sad feelings because they're embarrassed to talk about it. So we have to consider that. The people in long-term care really go unnoticed because their signs and symptoms may be that they're just quiet. And so the staff says, oh, she's just a quiet a client here, resident here. But that person may also be quite depressed. You should suspect depression if your resident has little or no initiative to do anything, is not involved in any of the activities that are going on in the facility. Um, if the person has experienced delirium, you can't accurately diagnose them with depression until the stage of delirium has passed or is resolved. So that's another difficult area there. If the person has had a recent life change, such as they just got admitted to the facility, or there's someone in the family or close to them died, they may also be experiencing grief and or adjustment difficulties, so that it's something to consider when you are looking at the older adult and depression. Okay, an older adult who has experienced physical and functional decline in their activities of daily living may also be grieving a loss of independence, a loss of autonomy, and that could be considered situational depression. So how do we detect depression in the older adult? Well, there are many, many tools that are out there, and I've only gave you a few, which are also in your reading. You look at their past mood behavior. What is the history of their mood? And that may be from medical records, from transferring, if they're transferring in somewhere, or family reports of the patient's previous mood state. Um, Watch for changes in their mood and behavior while they're there with you. Two key signs are sadness and loss of interest or pleasure in things that they normally enjoy. So if the person normally loved to do crossword puzzles and all of a sudden, they just stop wanting to do that, or they stop watching their favorite TV program, that's one of the signs. And then if they're sad in addition to that, then you need to suspect that the person is going through some type of depression. Additional signs you might notice is significant weight loss or weight gain, and they're not trying to lose or gain, it just occurs. They may sleep excessively or they may not sleep enough. They're tired, there's no energy. They give you expressions of guilt. They're very distracted from behavior. They can't concentrate. They give you a lot of vague but non-specific complaints of pain and aches in their body, but they really can't pinpoint it. If they're an outpatient, then you may see an increase in their use of healthcare services. And one of the things with older adults with depression, they may become combative or resistant to anything that you want them to do. They may display verbal abuse, which is very disheartening to family members. And it could even progress to delusional and paranoid behaviors when they start accusing you of stealing or poisoning them. Now, if you think about that, that's very close to a person that is becoming demented or cognitively impaired. And that is one of the reasons why it is so hard to diagnose them and why they often go undiagnosed, thus untreated for the depression. So there are different things that you can do. The first thing you want to do is determine whether there is a underlying cognitive impairment going on. Okay, so you may use the mini mental status examination. It's the most widely used tool. It's very easy, and it is a way to determine where their cognitive ability lies. One of the things you also want to do is always use the same assessment instrument each time you do an assessment with an older adult. Don't switch up the assessment tool, because you need that baseline of the same tool as you do your evaluation. The gold standard for assessing depression in older adults is the short form geriatric depression scale. It's used in the clinical area, the clinical setting. It can be used with a healthy older adult, a medically ill old adult, and even an adult that's mildly to moderately cognitively impaired. It's a 15-item question instrument. The answers are yes or no, and it only takes a few minutes for the person to complete it. It is best if the person can read and answer themselves, to allow them to do that, because if they fill it out alone, they're more likely to give an honest answer than if you're asking them and you're face to face with them. They may not be quite honest with what their answers are. The Cornell scale for depression and dementia is a 19-item tool that is administered by a physician or a person qualified to give a diagnosis, and it is interviews with both the client, the staff member, or family, people who know the patient best. Usually in the staff, it may be just the nurse's aide who's always there with the patient more readily than anyone else. It's a screening tool, keep in mind, and it's only used by those who can give that diagnosis of depression. Anxiety. Very underestimated in the older adult, not quite well understood yet. It is underestimated for several reasons, they believe. At one point, they thought that aging would bring about a declining anxiety, and that also because older adults are less likely to report emotional symptoms, and they put an emphasis more on their physical problems, and they will complain about the physical problems as well. Many older adults with anxiety disorder had them when they were younger, and so they weren't actually diagnosed, and they just assumed that their behavior was just incorporated into their personalities as they became older, and so they were never recognized as having anxiety. The aging process with stressors or chronic conditions and the losses that occur as you get older and the cognitive impairment, the loss of memory, and so forth, all can bring about anxiety in the older adult. Um, for older adults with dementia, anxiety can be triggered because of a change in the environment, because they are frustrated with the situation. There are also medications that can cause anxiety, and they include, but not limited to, antispasmodics, decongestants, thyroid medications can also cause that. Antidepressants, anticholinergics is one of the reasons why we are very careful when we administer in these to older adults. Neuroleptics, steroids, and even the anxiety drugs that are given to treat anxiety will cause anxiety in an older adult. There are three anxiety assessment tools that I have listed here. The Hamilton Anxiety Scale is something that you can get offline on the internet, and you don't have to have permission to use it. The Beck Anxiety Inventory was created so that you could tell whether the person was having anxiety or depression. And the Zung Self-Rated Anxiety Scale is really good with older adults who have cognitive impairment. Grief or bereavement. Oops, I am so sorry. Bereavement is a non pathological occurrence, but the person may still have to have some type of help to deal with their symptoms. It can come on very suddenly, especially after a death of a loved one. And I know you all remember Kubler-Ross and the stages of grief, which are denial, anger reaction, bargaining, depression. But this is much more deep and profound sadness than the depression that we talked about earlier. And then, of course, the last stage is acceptance of what's going on. The problem is when it becomes complicated grief. It's when the depression, that is when you see unrealistic feelings of guilt and sadness and lack of speech or slowed speech, and the person may even have visual and auditory hallucinations of the person that they lost, the deceased person, or they may even begin to mistake other people for the deceased person. And as it progresses, they have impaired functioning. They may have plans for suicides or suicidal ideations and thoughts. With normal bereavement, the symptoms diminish over time, but they reemerge when there's like a birthday or anniversary and so forth. But when a person is having complicated grief, it doesn't eventually fade away. It stays that way. And so this is when you realize that there needs to be some intervention done. Coping and burden. A fact of life is change, of course, and the three big categories for loss are loss in relationship of people, loss of ability or loss of the roles that the person has held before, and loss of objects or possessions. Burdens is how much physical and emotional responsibility a person has, and is generally based on losses and life changes. Caregiver burden reflects an external holistic demand to help an individual become, because of the psychosocial, the psychological, and the physical and financial dependency that the person they are caring for will need from them. Illness burden is the emotional impact of dealing with physical illness. And coping is how well a person can deal with all the burdens and the losses and the other problems of life. Coping with losses and burdens becomes a major task for an older adult. And a caregiver who has limited ability to cope with all of the things needed by the older adult may abuse or neglect the older adult, are becoming capable of caring for the older adult, which results in the older adult being placed into long-term care facilities. The assessment tools for burden and coping that I have here, and you will note that they are also in your reading. The burden strain interview, it measures the negative feelings about caring for someone, especially a person with a dementia. And the objective and subjective burden inventories measure your changes and disruptions in life and your emotional responses of the caregiver who's taking care of an older adult who has multiple health problems and needs. The Caregiver Strain Index measures physical, financial, personal, family strain that is experienced because the person is caring for a older adult or an older adult that has been recently hospitalized. The Caregiver Strain Index has many versions that have been modified to fit the situation, and it also has been translated into several languages and used across the globe to determine the level of strain a caregiver is experiencing. And then we have the General Perceived Self-Efficacy Scale, and it's a self-administered tool relating to the older adult's ability to cope with life, the changes that are occurring in life. Spirituality, a personal choice. Not everyone believes or practices spirituality, so then you would have to assess the person for that. It's hard for you to really define. It goes beyond the belief of presence of or absence of a God or a higher power, and it goes into include comfort gained through your belief. So before you assess the patient, you got to ask them whether they have a spiritual component in their lives. To do this, you can use what is called FICA. It's FICA. And FICA means faith is for the F. What is your faith or belief? Do you consider yourself spiritual or religious? And why do you believe in that giving meaning to your life? I is importance and influence. Is it important in your life? How have your beliefs influenced your behavior during this illness? And what role do your beliefs play in regaining your health? The C is community. And it will ask your patient, are you a part of a spiritual or religious community? Is this support for you? And is there a person or a group of people that you really love or are really important to you? And A is to address. How would you like me to address your these issues in your health care? You want to be cognizant of their spirituality or religious belief, and if they want you to address that into their care that you're providing, then you should do that. It is an issue when a person is experiencing spiritual distress, meaning that they feel like their deity has forgotten about them or is angry with them and has left them alone. You also see it if a person has done something in their past or present and they think that they're not worthy of the deity's love, and they start beating themselves up for things that they should have done or could have done or should not have done. They may experience some depression symptoms like crying. They may have suicidal ideations. They may express to you that they are afraid, that perhaps they have lived such a bad life and that their God or deity no longer loves them and that they're going to go to a bad place and suffer because of what they've done. And so now they have this feeling that they're all alone in this world and there's no hope. This is what's going to happen to them. So this is something that you can address. It may be that you need to locate the person's clergyman or spiritual guide or whatever is necessary to get your patient through this. And last and not least is life satisfaction. Emotional well-being can be represented by how satisfied a person is with their own life. And there are two tools that are used. The Life Satisfaction Index, a 20-item question, and the respondent answers is how they determine the patient's satisfaction with their life. And then there's the Philadelphia Geriatric Center Moral Scale. And it's also a 24 assessment tool. And it only requires yes and no answers. And it measures dissatisfaction, loneliness, agitation, and attitude toward aging. The point of this presentation is to let you know that normal aging is not characterized by mental health issues. So, if you suspect any mental or emotional health issues, it needs to be addressed and the cause needs to be treated. Thank you.